So welcome, everybody. I'm really pleased that Emily Frosch has agreed to talk about reactive attachment disorder today. I'm showing you our disclosure slide, although we're not talking about any aspect of Chattis today.
What is reactive attachment disorder, and then does anybody know what DSED stands for?
No.
Can't answer, but basically we used to think of RAD as having two types, the inhibited and, don't advance please, Barbara.
Okay.
Inhibited and disinhibited type. And for reasons that I'm not sure I really understand, in DSM-5 that was separated into two different conditions, reactive attachment disorder, which is still the inhibited type, and then this new name for the disinhibited type, which is disinhibited social engagement disorder. So it's a lot of mumbo-jumbo for really thinking about two sides of the same coin. So now, next slide. So we really began to think about attachment issues in the 1940s, really, when Renee Spitz, Mary Ainsworth, John Bowlby began to think about what was going on with some of these youngsters that were orphans or institutionalized during the war. And John Bowlby really started this attachment theory, which some of you may know a fair amount about. And that really comes from, John Bowlby developed it, and he was a British psychoanalyst, who was really trying to understand the distress that infants who'd been separated from their parents were experiencing. And he noticed that babies who were separated, and we see this in normal babies, go to extraordinary lengths. They cry, they cling, they look around to prevent separation from their parents or to get back to a missing parent. And we see this as normal separation anxiety, you know, where you hand the baby off to somebody and they like leap across what can seem like 6 feet to get back to their parents' arms, things like that. And at the time, we think of those as behaviors right now, but at the time, psychoanalytic writers really felt that that was manifestations of an immature defense mechanism to repress emotional pain and all kinds of things like that. And Bowlby really talked about these as attachment behaviors, that crying and searching were adaptive responses to separation from a primary attachment figure. An attachment figure was just defined as somebody who provides support, protection, care, whatever. And babies, like other mammals, can't do that for themselves, and so they are wired to seek out and look for and maintain proximity to these caretaking attachment figures. And Bowlby argued that over history and evolution, those babies who were better skilled at maintaining proximity would be more likely to survive to reproductive age. Felt that basically the attachment system that's hardwired in all of us is designed to answer the following question, which is the attachment figure that I need nearby and paying attention to me? If the child or the baby says, yes, that person is right here, they're doing what I need, they're going to be secure and confident and feel loved. And if the answer is no, there are going to be some problems. And whether it's anxiety or other kinds of behavioral problems that can start with this searching or crying or other things until either they reestablish proximity and all is well again, or they don't, and then you see this despair and a giving up, if you will. Next. Okay, so fast forward to the last 30, 40 years. So the first time this appeared in the official nomenclature of the world of mental health was in 1980 in DSM-3. And there it was very much similar, really equated with failure to thrive. You had to have the symptoms by age of 8 months. By 1987, they said, well, as long as it's there by age 5 years old, and you don't have to be a failure to thrive baby. By DSM-4, we had these two types of reactive attachment disorder, inhibited and disinhibited, and then in DSM-5, as I said, it split into these two different types. Next. All right, so what are the key elements of these disorders? Next. What's important about this is that it is very different from other DSM diagnostic entities in that it is very intentionally explicit about etiology. It is basically the behavior that results from an inadequate caregiving environment. And that environment leads to the development of aberrant social behavior that is true in all contexts. Okay. Next. So the kind of inadequate caregiving environment that we're talking about are maltreatment, institutionalized youngsters, kids who used to be institutionalized, then were adopted out. Sometimes it can be an extreme adversity, but there really has to be something severe and persistent in their environment. Next. More recently, people are thinking that maybe it could be less consistent across contexts, and maybe for some youngsters it could occur without a clear pathogenic care situation, but really the easiest way to think about it is there has to be something really bad early on from a caregiving standpoint. Next. It cannot be a function of autism, anxiety, or intellectual disability only. You might have those things in conjunction with this environmental situation, but it is not the social difficulties that we see in autistic youngsters. Next. Okay, so although I don't usually like to go through the DSM-5 list of symptoms and diagnostic criteria, I wanted to just do it quickly here. So for reactive attachment disorder, next, it's basically the pattern of emotionally withdrawn behavior toward adult caregivers, and it has to happen in both kinds of situations. Both the youngster will not seek out comfort when distressed, but also the youngster will not respond to comfort when they're distressed. So it is different than a easily distressed youngster who is consolable. Okay, very important distinction. Next. And then they need to have a couple of criteria. They need to not be very connected and responsive to others. They have a blunted range of affect at the positive end, and they be unexplained episodes of irritability or sadness or fearful even when the context doesn't really indicate a need to be afraid or sad or angry. Next. And then they have to have, as I mentioned, some sort of extreme of insufficient care. So social neglect, repeated changes in primary caregivers, or something that is an unusual situation so that there's no opportunity for these babies and youngsters to form a stable attachment to a particular specific person. Okay, next. So the environment is presumed to be the etiology, which is different than anything else in DSM where no etiology is referenced. Cannot be in the as a result of autism. Has to be before age 5. And although there can be intellectual disabilities, they have to at least be at the developmental age of 9 months. Okay? Next. So what does that mean for a PCP? What are you supposed to do about this? Next. So the downside is that there's no test, no study, no scan, no lab, anything that sort of makes this diagnosis. Next. Really, the only way to think about this is through taking a history. And we really do need to not just look cross-sectionally at the youngster who may be exhibiting social difficulties, irritability, seems withdrawn, but we really need to know about the living situation. Is it unsafe or unstable? Is there a parent with illness or absence? And that could be a psychiatric, substance, cognitive, or violence issue, or somebody who's disappeared. Housing insecurity. We take care of a lot of families who are intermittently homeless, maybe in and out of foster care. Is there abuse, emotional, physical, sexual abuse, domestic violence, witnessing any of those things as well. And then adoption. You know, for a while there was a lot in the media about adoptions, particularly from Romania and other Eastern European countries, where some of those youngsters had been in probably suboptimal institutional care for quite some time, and they were very poorly socialized, and some big headlines where families were sending them back on the plane and things like that. But I think some of those youngsters would certainly meet the criteria laid out here for reactive attachment difficulties. Next. So it raises this issue of what is it you have to look for in the patient as well as in the history of how their early exposure and environment. And so we do look for what some people would talk about very similarly with failure to thrive, perhaps without the growth and nutritional related components, but that sad and listless appearance, not smiling, not engaging. They might watch and be attentive, but not actually engaging. They don't want to play any kind of interactive games, whether that's at peekaboo or other kinds of peer-related games. They don't ask for help, and they don't respond to help when it's offered. Next. So what does that mean you're supposed to do if some of those things come up? Well, the first thing to do is find out whether the family has secure and a stable living situation with predictable and caring adults. It may be in this family, it may be in this living situation, but there may also be other situations. So you may have to think about where could this youngster be that would stabilize that situation? How do we interrupt some of the less stable situations that we're going to see in our kids and families? Next. And fundamentally, this isn't something that we go after with individual therapy for the child, and it isn't something that we use medication for. It's really about psychoeducation for the parent or the caregiver, and I think in this is a very complicated thing to just say. It really has a lot of parts to it. For some of our families, the caregiver may also be vulnerable in similar ways to the patient, and that may be partly why the patient is struggling with some of these things. They may have been psychiatrically unstable or cognitively or substance use related issues that led to instability for that parent, which led them to be in and out of the household, maybe in and out of availability and whatnot, which created the difficult situation for the youngster. But that parent may also have been poorly parented or suboptimally parented, and so may also be vulnerable and may not have optimal attachment skills either. And so sometimes we're targeting the dyad. Other times, the parent or caregiver that we're working with is the new, more stable situation, and we can work with them differently to change the environment for the youngster. So the other thing that is hard is that the literature suggests that these qualities that the youngsters who've lived through these tough experiences early on, they're pretty persistent over time, which means adjusting expectation and predicting some backsliding is going to be an important part of supporting the parents and families in managing these youngsters' difficulties. Next. It does mean, too, we have to help our caregivers listen to the youngsters without judgment, accept without retribution. Sometimes these kids can be very angry and irritable, and parents can get very frustrated. This isn't something that you tell the youngster once that they're safe and everything will be okay, and sometimes our families get very frustrated with having to do the same thing over and over again as though it doesn't seem like the child is learning, and sometimes they're not, and you just have to keep doing it over and over again. And sometimes that's a hard thing for our families to make sense out of, but we have to, a part of our responsibility as the primary care folks is to help them, both give them permission to be frustrated, but also to give them support and remind them that they are making a difference if they keep doing it. Next. We also need to make sure that the caregiver is in it for the long haul. Sometimes our caregivers get tired and decide they're done, and that's going to make the situation for that youngster even harder. And so thinking about foster parent who wants to adopt or things like that, really making sure that they understand what they're signing up for so that they don't get into it and then change their mind. Next. I think this is where sometimes I talk about some kids need industrial strength parenting. I would say that these are youngsters that need industrial strength attunement, so that the caregiver, the parent, or whoever it is, really is alert to what the environment and what the needs are of a youngster going into any situation or setting, school, social, whatever it might be, really be attuned to what might be overwhelming, what might be frustrating or challenging for their youngster, so that they can run interference, if you will, and optimize the environment and the experiences in a way that give those youngsters the least distress possible. Next. I think for some of these youngsters, we do need to think about other medical and consultations, whether it's nutrition, endocrine, growth. Some of these kids do have GI stuff, other things like that that we want to think about. There may be parenting classes that the caregivers could go to. Some parents will need individual therapy and or couples therapy to navigate the frustrating world of caring for some of these kids. Some of these kids will also need occupational therapy, physical therapy, speech and language therapy, other things like that, particularly depending on how long they may have been in this suboptimal environment. And occasionally some of these kids will need inpatient hospitalization because they are so poorly socialized and can tolerate social environments with so much difficulty that they need a safer environment. Next. So the flip side is this DSED, disinhibited social engagement disorder, which is pretty similar in a lot of ways, just manifests the opposite. So next. So these are kids who actively approach and interact with strangers. They're not shy, they're not cautious, they're not hesitant. These are the kids who sit on people's laps that they don't know. These are the kids who say, will you be my mother? Can I go home with you? Things like that. They don't check back to see who, the caregiver that they came with. They wander off. And they are often, because of this, very vulnerable because they're willing to go off with anybody. A lot of folks have seen like this where they sit on your lap and you're like, you just met them, or they hold your hand constantly, or they say, can I go home with you? That always makes me a little anxious. Something's not right. That's not typical for normally developing youngsters. Okay, next.
I just want to comment on that, Emily. Sometimes it's kids with ADHD who act like that, and so
So that's impulsivity, which is different.
It makes the hair on the back of your neck stand up, but it isn't always a problem in the attachment.
Right.
Some of the things that I think help with that is because they are equally effusive with their parent, and the parent is responsive. So it's not just dedicated to me, but it's also to the parents. Is that a valuable observation, or?
Not necessarily. It can be. The main issue with ADHD, though, and you can put up the next slide, is that's about impulsivity. That's about distractibility, squirrel, something catches their attention and they're off to the next. That's different than socially disinhibited behaviors. These kids may not be impulsive. They just, they're not distractible in that by something shiny. That's not what this is about. It's more just, oh, you're a person, I'll be your best friend. As opposed to, I'm going to grab the ball, I'm going to run into traffic, I didn't, those kinds of things. It's a very specific to the way they interact with humans, as opposed to being impulsive.
And how about, would it help if it's more specific to going towards adults versus peers? Does that make any difference in your?
These are adults. If you look at the criteria that are up on the screen, it's about interacting with unfamiliar adults, without checking back to the adult caregiver, willingness to go off with an unfamiliar adult. And that's the pattern of behavior, approaches and interacts with unfamiliar adults. Yeah. Next. These kids, though, are having an opposite response to the same difficulties that are required in the diagnosis of reactive attachment disorder, okay? Extreme patterns of extremes of insufficient care as listed there, okay? So it's, for whatever reason, some kids respond in a withdrawal way, some kids respond in this disinhibited way. Next. Again, the care is the etiology, the environment is the etiology for the disturbed behavior, and the kids are at least developmentally 9 months or older. Next.
Can you comment on kids where the parenting seems to be good, but you don't know what they're getting at their 8 to 12 hours of daycare?
Well, I don't worry about that too much if parenting is good, because it has to be, if you go back a slide, a pattern of extremes of insufficient care. So social neglect, deprivation, persistent lack of having basic emotional needs. So if they have parents that are doing an okay job, even if it's only a few hours a day, that's okay.
Mm-hmm.
That's not the same thing as kids who are in an institution with inadequate staffing and nobody takes them out of their crib all day, where there's nothing. As long as you get some, you're going to be okay. Okay. So basically, for the PCP, it's the same. Next. Next. No test, no study, no scan. You have to take the thorough history so that you know who's at risk. And it's the same sets of issues for the parents and the environment. Next. Next.
Yeah.
Next.
Yeah.
So one of the things that we want to be thoughtful about is that in some environments, being friendly to adults could be okay. So we do want to make sure that it is outside what would be considered reasonable in that microculture. So in some situations, it could be okay. If everybody is raised in a communal way, then maybe being friendly with everybody isn't weird. But we want to think about this from a developmental standpoint. For toddlers get anxious when new adults approach them. And if they don't, that's a red flag. In the preschool years, if there's a lot of attention-seeking behavior with strangers, or they're very verbal and connected to strangers, those are red flags. And there are some red flags in middle childhood and adolescence as well that we need to at least look into and see if they keep company with some of these other things that are worrisome. Next. Next. So again, very similar. You really have to take a history about the living situation, who's there, who's doing what roles and responsibilities do the adults have. Next. And we need to think about what the relationships are between the adults and the youngster. And again, this is a lot of psychoeducation for the parents or caregivers about how it might impact them, what it's like to care for a child who's in this situation and has these behaviors. And then for this group of kids, we really have to be thoughtful about their safety. They wander off, and they are very vulnerable to being exploited. So that's something really, really important. Next. Next. So similar risk factors and patterns of prior experience are required in these two versions of attachment issues. Next. They have similar exclusions. You know, you can't be autistic as the cause, you don't have ADHD as the cause, and there isn't some other psychiatric disorder that leads to these problematic issues. Next. Similar early onset, really in the first few years. Similar link between the environment and the exposures and the timing of the behaviors in response to that. Next. It's just a different manifestation. One is an inward pulling and the other is an outward response to it. Why some kids respond in those ways, we don't know. Probably has to do with their hard wiring and what their dimensional strengths and vulnerabilities might be that they respond to it in a particular way. Next. 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 There's not great longitudinal data here. It does look like there's a particularly high stability for the more disinhibited states and moderate stability for the withdrawn state. Next. And the longer they're in the pathogenic environment, the worse the outcome will be. And there's likely, if they really meet these criteria, there's likely going to be long-term functional impairment in their relationships. Next. The good news is that a lot of kids have tough early life exposures but will do okay. Why some kids have more trouble, we don't really know. If the environment is bad enough, all kids will have trouble. And so that's something to be aware of as well. Next. Basically, the main intervention we have is to help the adults do better by kids. We don't have any particular intervention, no meds, no individual therapy that will target this for a youngster, unfortunately, at least not at this point. So I'm going to stop there. Questions, anything people want to talk about?
And it's a little confusing because some of the symptoms, my nurse and I are looking at the presentation, and it seems that few of our patients match a lot of the description without having necessarily the full history of orphanage or adoption, but they do have a certain amount of loss. So we have a mom with substance abuse issues with the baby basically staying in the crib for prolonged periods of time, or we have a 19-year-old with a mom that is never at home, that moved to California, left him with family members, completely withdrawn, having serious issues attaching and trusting. I have another teenager whose mom is a nephrologist in France, daughter is pretty much on her own, 17 years old, sees mom maybe once a month, and they do have issues. So they do have other emotional issues. They do have, I do think my older adolescents or young adults have more depression symptoms, but it is hard for you only to call them that and maybe not being part of other diseases. So how do you separate them?
Mm-hmm. So good question. I think one thing is that for the 17 and 19-year-old you described, the loss deprivation has to have happened when they were little. It's not just that it's as they get to be adolescents, then their parents disappear or leave them or whatever. Those experiences have to happen very early on in infancy and early childhood to meet the criteria for these particular descriptive diagnoses.
I see.
So that's important. It doesn't mean that those events in life are not problematic for our youngsters, right? So depression, anxiety, potentially PTSD, depending on the circumstances, all of those things can be present in the older youngsters who experience that kind of loss, disruption, and betrayal of their nuclear family. I think that some personality types or styles are more vulnerable to having trouble than others, and then some youngsters will have a genetic vulnerability to major mental disease, so depression, serious anxiety disorders, and whatnot. So I think you have to sort of separate out and think about what is the disease that a person might have, depression, for example, what is their temperament and dimensional vulnerabilities. I think adolescents in those situations, sometimes with low IQ, have more difficulty making sense out of and understanding or finding a way to tell their story or create a more positive narrative than youngsters who may have a more brain power, if you will. Some of those youngsters will have other family members who offer constructive role models or ways to handle their grief and frustration. Some of our teenagers don't have that, so they simply are left to their own devices to try to make sense out of the overwhelming emotions. And then some of our youngsters develop maladaptive behaviors that unintentionally get reinforced by their living situation. So whether that's potentially substance use or cutting and getting a response to it, or other kinds of less adaptive behaviors can be part of the presentation. So I think it's really important to tease out whether that environmental deprivation happened early enough to have disrupted permanently the capacity for connection, trust, and sense of a safe and stable relationship. If it happens later, it's not reactive attachment disorder. It's still important, but it would be called something else.
Something else.
Does that make sense?
Okay. Yes, it's because there are, what you describe in the DSM-5 and in some of your criteria. Yes, it says youngsters, which is also kind of difficult to go back to pretty much tease out unless you are an adopted child or unless you are an orphan or someone that came from very, very, like, foster children that come from very disruptive environments. But a lot of the symptoms of some of these young people are about betrayal. Parents have betrayal for one or the second reason, and they do behave like this. They mistrust, they become disinhibited, some of them become completely withdrawn. And yes, there are other issues going on emotionally, but it seems that they also are having a little bit of an attachment issue with their family members and with their closest relatives. And I thought that there was an attachment disorder for adults as well, or am I wrong?
I don't know.
You don't know?
I don't know. I think that you raise a really important point, though, which is when our youngsters, when our kids, teenagers of any age, see the adults in their life not handling things well, that's important. Those are the people to whom our kids are looking for models for how to do all things. So how do we handle conflict? Do we hit each other or do we talk about it? How do we handle our strong emotions? Do we yell and scream and threaten to kill ourselves, or do we talk it through and get help and support? All of those things are important, and when some of these situations may be multi-generational, and so the kids that you're caring for, whether they're children, middle school, or adolescents, may not have ever learned how to optimally cope with what life has to throw at them. And it may be that what life is throwing at them is awful, but it may also be that it's the usual life stuff. And so some of our kids will have trouble managing the regular life stuff. Some of them will do okay with that, but when it comes to the big ones, they're going to have more trouble. So this is where taking a family history around who are the well-coping grown-ups and who isn't coping so well is going to be really important for several reasons, not only because it's telling you who's modeling what kinds of things for the youngsters, but who can you turn to be part of the treatment team. Because sometimes our families are not well enough themselves to be part of the solution just yet. And so sometimes getting parents help before you're going to ask them to engage in helping the youngster is going to be an important step.
I see.
I'm sorry. I wanted to bring out a primary care, a little different primary care perspective on this. We're talking about diagnosing children who have a dismal outcome and with a great amount of intervention. And I think that it's really important for us to think through the primary care perspective when we see babies and think about the mechanism for this has been well worked out. Mary Ainsworth, Sally Province, early on, when you see lack of a contingent, that's time-related response to the expressed needs of babies, the differences show up, by 6 months in their studies. The amount of mastery motivation, that is, as 6-month-old has the zest for life and wants to grab out to an interesting object. There are differences based on what happened in the first 6 months. Who's there witnessing this? Primary care pediatricians get to see it, and what we're talking about really is the interaction, the moment-to-moment interaction between the caregiver and the infant, responsiveness, and that's a different perspective. That's not talking. That's really looking at depriving circumstances, parent-child interaction, and that. If we care about this, that should be part of the examination, a history taking and an examination when the mother has less reflexes to respond to protect the baby from the shots. And you can notice, of course, you can see some reaction patterns in the office and by history. And for the pediatrician to attend to this very early in a preventive way is going to be the solution for this kind of problem, way beyond doing something once this is a well-established pathology that we've been talking about. So I don't want to lose perspective, and this is a strategic position that primary care pediatricians are in a unique position to do. And their colleagues in child psychiatry will see them when they're going to school. But the ball game's over by then to a large extent. So I just wanted to be sure we talk about that perspective.
Yeah, Emily, there are some programs. I think one of the problems for all of the people on the call here and pediatricians in general is, what kind of resources can we do to help parents learn to be more responsive? And there are two programs that have good evidence now, besides what a psychiatrist might do or a psychologist might do. One is called Parent-Child Interaction Training.
PCIT?
And PCIT. And another one, which is basically PCIT, is put out by the Incredible Years. I think I'm showing it on my screen now. Can you all see that? I can only see. Yeah, good. Something to think about, because if you have a particular interest in this, or you have a member of your staff who would like to be more skilled in this area, these are both things that have training programs. Both PCIT.
Barbara, PCIT is not specific to reactive attachment. That's just a behavioral parenting model.
Not at all. Yes,
not at all.
I'm aware of that. But
okay.
If people are seeing kids with this problem, they're probably thinking, what are the resources for trying to help build the skills of parents, or for foster parents who've taken on a kid like this, who have the compassion, but they don't necessarily have the skill set. How can you find help for them? And these are two things that I might recommend. Do you have other things that you would recommend, Emily?
I like the Chicago Parenting Program.
Mm-hmm.
And I also like, and it might be particularly relevant, Circle of Security. Circle of Security is a program that uses attachment theory as the driver behind the intervention. It's it's really a more normative approach. It's not designed specifically for youngsters who have pathological problems of any kind, but it teaches parents what normal attachment looks like. Some of our parents have difficulty with the normal going out and explore, coming back to sort of check in. They either see the going out to explore as a rejection and they get angry, or the coming back to check in is seen as their kid is too needy. So it teaches what the normal circle, what they call the circle of security of going out and coming back, which is a normal experience in infancy, toddlers, and young kids. Oh, sorry, we're getting a flash flood warning on our phones.
Yep.
That,
people in Tulsa, can you relax? This is a Baltimore flash flood warning.
Yeah. It just helps parents understand that that's a normal cycle of development. And so I really like the Circle of Security program because it teaches a different model that could be very helpful, I think.
When we're talking about, mostly these are for slightly older kids, on the Circle of Security is wonderful, and they also point at observation during immunizations and how a mother responds, that they have some objective data. But beyond that, it can never hurt. You're doing developmental screening, and the notion we've come with is to identify kids who are delayed. Well, those particular developmental milestone activities, like the ages and stages, involve, if the kid is already doing it, it involves some activities that are joyful and engender a responsiveness in parents and their babies. It can never hurt to prescribe those kinds of activities. And actually in Chattis, when they do the ages and stages, we put the milestones that they already do in their virtual baby book with suggestions for activities, and those activities are at the sort of the cusp of the infant's development and are ones that are joyful. If it'd be an activity would be like playing peekaboo would be one if they're just beginning to do it, and when so that we try first to have the baby seduce the parents, and sometimes the parents are just not available and they have substance use or other things, and it's sort of a family intervention to see if there's someone else that can be a appropriate caregiver in the meanwhile while the biological parents repairing themselves. So I think that that's the level of we think of it as for developmentally delayed kids, but kids who are not getting their needs met and need some joyful, responsive kinds of interactions, you can point to those things immediately. It's not going to hurt anybody for that kind of intervention.
I'd like to hear from other people on the call here what kinds of experiences you're having and what questions you have.
You want to just point out what you have on the screen?
I did. So this is the Memory Book Care Portal in Chattis that's available to every parent. Their milestones appear here, and next to the milestone will be a suggested activity link. They're pretty simple, but they come from the authors of the Ages and Stages Questionnaire, and they're relevant to what the child can do now. There's an activity relevant to that child.
So we call that a developmental prescription. It's a kind of prescription. It's not medication, but it's right there available for you to access.
So other people, how about?
Yeah, well, the problem is, we have kids coming in with, they come in with the behaviors. The kids come in at different points, getting insurance, off insurance, changing insurance, and so they, show up with the symptoms. And I think, we for the primary care physician, getting enough information to really help, not just saying, okay, I'm sending you to psychiatry. What we can do, in the, exam room, what can, because we're, we have some younger kids, but I don't think we see, I think we make enough relationship then. It's that the kids that show up later with symptoms is our problem.
Emily, you want to comment on that?
Is there something you had in mind, Barbara? I don't have anything.
No, just it's painful to see. Sometimes it's hard to repair, but you don't want to just give up on a kid because they had a rough start. And so I think Emily's slide that said some of these kids get over it is really important, but they need the right kind of help. And I think that one of the things that comes up for me is looking for any other person in the family who is perhaps better able to care for the kid, and trying to engage with them yourself. Like, in other words, invite them to come in for the visit. I've had some daycare providers where that's where the kid is getting their benefits. That's where they're getting their nurturing. And I call them up and try to get them to not kick the kid out of the daycare because of some of the behaviors which they may not understand, because they are the one with the best skills in the mix. So there are some things that you can sometimes do to encourage those supports to be included. Sometimes it's a grandparent who was rejecting of the parent because they became a drug abuser, for example. I've got a bunch of those in my practice. And so they don't want to have a lot to do with the grandparent because they don't want to sort of encourage the drug use of the parent. On the other hand, the kid is living in this neglectful situation, and so encouraging the grandparents to take a more active role can be one of the things you might suggest. Does that ring any bells, Suzanne? Or
oh, yeah.
else?
Yeah, we do have a lot of grandparents come in, and the grandparents always want to try to, talk with us before we, see the child with the parent. So that's one way and the grandparent will tell us some of the information. But that seems a common situation, especially, with the parents using, drugs, substance abuse, right, and not being present for the child and trying to, sometimes it's hard to work that out, that the parent doesn't want to let the grandparent in sometimes. And, I mean, how, what do we have to sometimes get? I guess we have a social worker now, a pediatric social worker to help, because before we didn't have a pediatric social worker, some of these times, we would be calling CPS when that might not have been the right thing, but we couldn't get the parent to let, these other people in.
Right. It's a careful. The grandparents have to do a careful kind of dance in some cases because the substance abusing, and boy, it's a lot of it's substance abuse is what's going on. They're sort of hostile. They want to get the child support for the kids, so they've got that kind of in their interest. They're ashamed that they aren't letting their kid down, so they don't want to sort of admit that they've let their kid down. So helping them to find a way for the grandparent to get into their life and encouraging them to say, every kid needs a godparent, every kid needs a grandparent. It takes a village to raise a kid, and it doesn't mean that you're not doing a good job, even if you really think they're not doing a good job. It's something that the kid needs also. And you need a break too, you can start to say, because often there's a fair amount of neediness in the parent who's a drug user, may be quite self-centered, and the sort of going towards some of their egocentricity to encourage them to take a break and let the grandparent have more of a role are some of the kinds of conversations that may help them accept the grandparent, particularly if you can get the grandparent to be sure not to be judgmental when they're interacting with the parent, just in order to save the kid.
I think what Barbara's saying is sometimes it's okay to blame the little baby and the kid. We actually don't know in these interactions. Some babies are extremely difficult for any parent, and to be able to, when in doubt, to put it on that it may be that child is very, very challenging, and that gets the parent a bit off the hook, as Barbara's saying, and more open to getting some help and replacement. This condition, it was, as Emily started talking about the 40s when Spitz observed these kids that not only failing to thrive or not surviving, and Sally Province in the 50s showed that they were behind in language. And now, even today, especially as Romania is one place where it's being studied so much, but we're seeing in these institutions and documenting with our modern technology now by MRI, EEG, that their brains are not the same in the first year of life. And and there are those interventions that have made a difference, and these neurobiological outcomes have to do with appropriate foster care placements and adoptions very early on. The other side of the coin is that, as Emily also alluded to, we had this spate of Americans, particularly, and we've got this international conflict from Russia, because most of those were fetal alcohol as well as being deprived. Those kids, you adopt those kids, and I have seen that just wonderful families who've been very successful raising kids and feel like they want to go out and do more, get destroyed by the kids who are so difficult, and so the lack of prevention leaves us with this very sorry circumstance of kids who need a whole team to have some semblance of humanity at the end of it.
I have two questions. Okay.
Sure. Go ahead. No, go ahead.
Okay, one question I said, does anybody, when they're doing their well child care, routinely identify these people that are helping, that are your support? Because you know how we have all the questions we ask, do you eat, do you give your kids fruits, what do they say and all that? Does anybody routinely ask them that? And my other question was because we have lots of bilingual kids, but that's not blaming why they have language problems. They're lower socioeconomic group and, illegal immigration. But when we're seeing a language delay, I guess how much should we be thinking about this?
Well, we should be thinking about it before it happens is what I'm suggesting.
I think that when we ask about who's helping you take care of your child, that we're trying to find out that information. Now, it's not exactly a questionnaire. Kathy Kemper has a nice questionnaire that includes a simple way of looking at social support. But I think that that all of us want to know, where is your child spending their day, and what do you think of the caregiving they're getting there? It's funny. We do think about that all the time, I would say, for children who are before school age. And then when they go off to school, sometimes we forget to ask who else is taking care of the kid. So at that point, it's too late to develop reactive attachment disorder, as Emily said. But I think your question about, who's involved in taking care of the kid really does need to be part of the routine. And it usually is, because we're finding out, just who's there keeping the kids safe is the first question that leads to finding out who might be there to support the kid as well.
So one of the things at the 1 month visit in these teleprompters that we're trying to create through Chattis is asking about, have they thought about getting who's going to be a godparent? And that's a way society has sort of sanctioned this kind of role, and having them think about it early on before there's a problem. That's a useful thing for all families. And so that's one way to begin the conversation, and we think that 1 month visit is a good time to begin it.
Right. Oh,